Hello, and a very warm welcome to our webinar today on reducing your risk of lung and bowel cancer. Today's webinar is for the general public and is focusing on two of our commonest cancers, lung and bowel cancer. Almost 2,600 people are diagnosed with lung cancer and over 2,500 people are diagnosed with bowel cancer each year in Ireland. With our speakers today, where if they mention any useful links, we'll share those in the chat function, and they'll also be sent by email to those who've registered for the live webinar. Please do note that we can't answer any individual medical queries and suggest that those would be most appropriately discussed with your GP. The webinar today is hosted by the HSE's National Cancer Control Programme on behalf of the Irish Cancer Prevention Network. And I'd now like to introduce a short video on the Irish Cancer Prevention Network. Everyone's risk of getting cancer is influenced by a wide range of factors. And although there are things that we can't change, like our age and genetics, there are also factors that we can change, like if we are active, what we eat, whether we drink alcohol, and how we protect our skin from the sun. It is estimated that 30 to 50% of all cancer cases are preventable, and we can all take steps to reduce our risk of cancer. This is why cancer prevention has been a cornerstone of Ireland's National Cancer Strategy since 2017, as it offers the most cost-effective long-term opportunity for the control of cancer. The Irish Cancer Prevention Network, or ICPN, was formed in 2018 to reduce the impact of cancer on the lives of people in Ireland. Its members support and collaborate on national initiatives around cancer risk reduction. ICPN is made up of Breakthrough Cancer Research, the HSE National Cancer Control Programme, the HSE National Screening Service, Irish Cancer Society and Marie Keating Foundation. Breakthrough Cancer Research fund research, including prevention research, focus on low survival cancers, such as improving management of precancerous conditions like Barrett's esophagus, and provides expertise and patient resources on the impact of diet on cancer. The HSE National Cancer Control Programme works with health service providers and other partners to prevent and treat cancer and increase survival and quality of life by converting knowledge into strategies and actions. The HSE National Screening Service runs 3 population-based cancer screening programs: Bowel Screen, Breast Check and Cervical Check. Their vision is to work together to save lives and improve people's health. The Irish Cancer Society work to ensure that more people learn how to reduce their risk of cancer and detect cancer early, advocates for improved health policies, provides information sessions and delivers national awareness campaigns. The Marie Keating Foundation has a range of awareness and education services focused on reducing cancer risk through lifestyle choices and highlighting signs of common cancers and how to spot cancer early. Since its launch in 2018, the ICPN has developed evidence, guidelines, information and resources around modifiable cancer risk factors, produced a quarterly newsletter for over 1,000 subscribers, delivered a free e-learning program on reducing cancer risk for health and social care professionals, delivered annual webinars for the public and health and social care professionals on key cancer prevention topics and themes, and supported the implementation of the National Cancer Strategy and the National Skin Cancer Prevention Plans, with much more planned into the future. We recognise and appreciate the role of those active in community prevention, academia and others, and invite interested groups and individuals to partner with us to grow the network further. We're open to hearing your ideas and feedback. Cancer prevention is a national effort, and we are confident that together we can continue to raise awareness of cancer risk factors and ensure that people are provided with the information and support they need to adopt healthy lifestyles across Ireland. I'm now delighted to introduce our first speaker for today. That will be Dr. Una Kennedy. And Dr. Una Kennedy is a practicing GP in Dublin and also works as the GP advisor to the National Cancer Control Programme. And today, Una is presenting on reducing the risk of lung cancer and the importance of acting on potential early signs or symptoms of lung cancer. So over to you, Una.
Thank you, and good afternoon, everybody. I'm going to speak about how to reduce your risk of lung cancer. So where do we stand with lung cancer at the moment in Ireland? Lung cancer is not our most common cancer, but it is one of our most common cancers. It is the third most common cancer in males in Ireland and the second most common cancer in females in Ireland. And while it is not our most common cancer, it is our most common cause of cancer death. Currently, we have about 2,700 cases of lung cancer every year in this country. To think about how to reduce our risk of lung cancer, we need to think about the risk factors for lung cancer, the things that can increase our risk of developing this cancer. Risk factors can be broadly divided into non-modifiable things, that's things you cannot change, and modifiable things, that's things we can change. Non-modifiable risk factors, the things we cannot change, can include our age. We can't control the fact that we're getting older, our family history, a diagnosis of smoker's lung disease, being a smoker in the past. Being a passive smoker isn't something we can always control, and we can't always control our environment and our exposure to radiation. Modifiable risk factors, the things we can change, include smoking and radon. To begin with radon, radon is a gas that occurs naturally in our environment. It's produced by soil and stones, and it's all around us, and this is not avoidable. Exposure to radon over a long period of time can increase our risk of lung cancer. In fact, in Ireland, about 350 cases of lung cancer, that's 13% of all cases every year, are caused by radon. The risk from radon is far greater for smokers than for non-smokers. Smokers are more susceptible to radon. However, although radon in the environment is outside of our control, we can address and modify the radon in our home. And for more information about this, you can log on to the Environmental Protection Agency website, www.epa.ie. Smoking is the biggest modifiable risk factor for lung cancer. Smoking causes about 80% of all lung cancers. Even if you don't smoke, passive smoking increases your risk. A smoker only inhales about 15% of the smoke from a cigarette. The other 85% goes into the air around them or is inhaled by others. Opening a window isn't sufficient. When you smoke, that won't make a difference. More than 80% of the smoke around you is invisible. You can't see it or see where it goes or control it. The best thing to do is not to start smoking, or if you do smoke, quit. And where do we stand in regard to smoking in Ireland at the moment? Well, we have seen a reduction in the numbers of people smoking in this country over recent years. It's reduced from 23% in 2015 to as low as 17% in 2019. However, in recent years, unfortunately, smoking levels have stalled at about 18%, so about 1 in 5 people in this country smoke at the moment. And it's not just the risk of lung cancer. Smoking has an impact on so many areas of our lives. Just shy of 1,000 people per week will be hospitalised as a result of smoking, and a little under 100 people a week will die as a result of smoking. And that's not to even mention the cost to the health service and other problems caused by cigarette smoking. The good news is that people who smoke want to quit. About 2 in 3 people who smoke want to stop, and indeed 1 in 2 people who smoke have tried to stop. The problem is that too many people go it alone and they try to quit without getting any help. And there's loads of help out there. This is a list of some of the supports that the HSE provides to smokers to help them quit. And you should be able to find one that suits you and that can be tailored to your needs and will work best for you. If you want to quit, if you're curious and if you think you could do with help, I'd suggest you start by logging on to the Quit website. Log on to www.quit.ie, put it into your search engine. That will bring you to this page where you can click on Stop Smoking Clinics. If you click on Stop Smoking services, it asks you to select a service area. This is a geographic location for smoking services, and obviously you should select an area that is close to where you work or where you live and that's convenient to you. In this case, we clicked on Limerick, and you can see there are 9 places around Limerick that offer smoking cessation services. You can see 2 of them pictured here, and you can also see that the names, the emails, and the phone numbers of the people who run these services are here. I phoned one of them recently, and I'm very glad to say that they did phone back. I did speak to a human, and they were very helpful and informative and enthusiastic. They can offer you smoking cessation counselling courses, and they can also offer you nicotine replacement therapy. All of this is free of charge thanks to the HSE. This is what your smoking cessation course might look like. So you're looking at about a 6-week course, and they also follow you up at 12 weeks, at 24 weeks, and 56 weeks after you quit. In addition to the supports they give you, be it individual or group counselling, telephone support, text message support, internet-based support, they also offer stop smoking medication. And this could be in the form of medicines or nicotine replacement therapy. That would be your gum, patches, or inhalers. And all of this is free from the HSE, even if you don't have a medical card. So there's really no reason not to make contact. Not every lung cancer can be prevented, and if you do develop cancer, you do need to know what signs and symptoms you're looking out for. It's very important that you know the signs of lung cancer and you contact your GP as quickly as possible. Treatment options are better, and survival is so much better if you can find cancer early. You're watching out for a new cough, a cough that could last more than 3 weeks, or for a change in your usual cough, or breathlessness more than is normal for you. Watch out for coughing up blood, for unexplained chest pain or shoulder pain, for chest infections that keep coming back despite treatment. And then there are some symptoms that you might not particularly associate with lung cancer, such as loss of appetite, feeling extremely tired in a way that's unexplained or unusual for you, or for weight loss that's unexplained or unexpected. And really, any symptoms that are unexplained or unusual for you merit getting checked. What happens next if you do have symptoms and if there's concern for lung cancer? Ireland has 8 rapid access lung clinics dotted around the country. Your GP can send an electronic referral to one of these clinics. They'll receive that immediately, and if they are concerned for lung cancer, you can expect to be seen in a few weeks. So what do you need? Overall, cancer survival in Ireland is improving. There are now over 200,000 people in Ireland living with a cancer diagnosis, and that's a 50% increase in the number of cancer survivors compared with 1 decade ago. Indeed, between 1994 to 98 and 2014 to 2018, lung cancer survival has increased by 15 percentage points. So what do you need to do today? If you are a smoker, try to quit, and please seek help, and I'd urge you to contact quit.ie. If you have symptoms, don't be scared, don't delay, contact your GP today. And finally, for anyone who wants to see that list of symptoms again, or who would like to have a copy of that list of symptoms, you can find it on our website at hse.ie/cancer prevention. And there are many other cancer resources available on healthpromotion.ie. Thank you.
Thank you, Una. And Una's going to join us at the end of the session as well for our panel discussion. I'm now going to introduce a patient story from Mary Kennedy. So Mary Kennedy is a patient advocate who was diagnosed with bowel cancer that was found through the bowel screening program. She's a very active lady who swims, walks, and takes part in yoga. And she's here today sharing her story to encourage people to take part in the bowel screening program.
I had no symptoms, absolutely no symptoms. I was quite fit, I was walking, I was swimming, I was very active, I was doing a bit of yoga. I was going along, you know what I mean, doing everything, enjoying life. and not having any symptoms, and then realising that I had cancer. That was a big shock. My name is Mary Kennedy and I'm 61 years of age. I had heard of the bowel screening programme through the radio and through friends talking about it. When I was 61, I got the letter from the bowel screening programme to kind of invite me to apply for a kit. I applied for the kit and it came probably a week later. The instructions with the kit were crystal clear. It was very, very easy to do, and it took me by surprise like how easy it was. And I sent off my sample, and probably less than 2 weeks later I got a letter to say that blood had been seen in my sample. I suppose that was a bit of a shock. So shortly after that I got a call about going for the colonoscopy. So following on from the colonoscopy, it's actually told that I had cancer. I suppose to be told that you have cancer is it's a big shock. It's a lot to take in. But the nurse was really good and she explained to me what would happen, what it entailed. A consultant who was going to take me on as a patient to go for a scan and then to go for an appointment. So I went for a scan, went to see my consultant, and he told me the good news then was that the cancer hadn't spread. It wasn't in my lungs or my liver, which was great. The consultant, he just drew a diagram and explained everything from start to finish, what the operation would entail, possible side effects and all of that. You know, I mean, even the day before I went in for my operation, I had, went for a big swim that morning. So I wasn't tired, I wasn't lethargic, so that was the hardest part of it all, the fact that I had no symptoms. It was also great that I was caught. It was caught so early. I went in for my operation. I was in hospital for a week, and when I came out, I got excellent care in the hospital. I couldn't fault it for a minute. It was really, really good care. When I came out of hospital, then 2 weeks after I came out of hospital, I went to see the consultant and got the great news that the cancer had been caught early, that the cancer hadn't breached the lining of the bowel, and that my lymph nodes came back clear. So that was a great relief. And he said the only treatment after this would be surveillance, where I would be going for regular checkups, regular colonoscopy, as in yearly. And that was very reassuring to think that I was going to be still looked after the operation. So I feel very lucky and very grateful that I got such a good diagnosis. I suppose I can't speak highly enough about the bowel screening programme. I think it's a fantastic programme to have out there. Speaking from personal experience, I was one of the lucky ones. I've encouraged all my friends to do it, and they've encouraged their friends to do it. And to think that it was got early and that I'm cancer-free now, that was very reassuring. That's why I feel I just want to shout it from the rooftops to tell everybody to do it, because it's so worth it.
And we're very grateful to Mary for her generosity in sharing her story. We'll have two speakers now in the area of bowel cancer. The first speaker will be Dr. Katrina Kelly, and Dr. Kelly is a public health doctor in her final year of training. She qualified as a doctor from UCD and also has a master's in public health. But prior to working in public health, she trained in general hospital medicine, and from her time working in acute hospitals, Katrina has had a strong interest in preventative medicine. And today she's going to talk about the modifiable risk factors for bowel cancer. So over to Katrina.
Good afternoon. My name's Katrina Kelly and I am a public health doctor. And this afternoon, I'll be talking to you about the steps that you can take to reduce your risk of bowel cancer. So what is the bowel? Well, the bowel is just one part of our digestive system. So when you eat, you take food into your mouth, goes down your esophagus, into your stomach, and then into the bowel. And the function or the purpose of the bowel is to digest your food, to absorb the goodness or the nutrients from your food into your bloodstream, and then to process and to expel any waste that your body cannot use. And so the bowel is divided, roughly speaking, into two parts. There's the small bowel or the small intestine and the large bowel. And the large bowel is made up of the colon, the rectum, and the anus. When we talk about bowel cancer, we're really talking about cancer of the large bowel, so of this part of the bowel here. So you might hear it referred to as colon cancer or colorectal cancer, but these are just different names for bowel cancer. Each year in Ireland, over 2,500 people get diagnosed with bowel cancer, and it affects both men and women. But there are steps that we can all take to reduce our risk of bowel cancer. So what are these steps? Well, they include things like eating a healthy, balanced diet, being physically active, maintaining a healthy weight, limiting our alcohol intake, not smoking, or if you do smoke, quitting, and taking part in bowel cancer screening. And I'll go through all of these in a bit more detail. So what do I mean by eating a healthy, balanced diet? Well, evidence shows that a diet that's high in fiber leads to an increase in the protective short-chain fatty acids within our body. Equally, fiber is very good at protecting against the damaging effects of bile or bile acids in the body. And so these can all help to reduce our risk of bowel cancer. On the flip side, foods like red meat, so steak, beef, pork, and processed meats such as bacon, salami, and sausages all contain chemicals such as heme or N-nitroso, which can damage DNA and as a result increase our risk of bowel cancer. So what can you do to reduce your risk of bowel cancer when it comes to your diet? Well, you can eat foods, plenty of foods that are high in fiber, such as fruit and vegetables, whole grains, and pulses like lentils or chickpeas. And you can reduce your intake of red meat or processed meat. So things I would suggest would be perhaps eating an extra portion of vegetables each day, or have one day a week where you don't eat any meat. So have a meat-free Monday and build it from there. There's plenty of recipes online for tasty vegetarian curries or vegetarian stir fries. And remember, it doesn't have to be an all or nothing approach here. You can start small and build it from there. Being physically active, I'm sure as you're all aware, has many health benefits. But perhaps you didn't know that being physically active can actually reduce your risk of bowel cancer. And it does this by helping your body to use a hormone called insulin more effectively. It reduces the inflammation within your body and it helps you maintain a healthy body weight. So what can you do to reduce your risk of bowel cancer? Well, the guidelines recommend 150 minutes of physical activity each week, as well as some muscle strengthening exercises. However, really any amount of physical activity is better than none. And by physical activity, I don't just mean going for a run or going to an aerobics class. Even things like taking the stairs rather than the lift, walking or cycling to work, even gardening and housework can be considered physical activity if they're active enough. So try and introduce a bit more movement into your day wherever and whenever you can. Keeping your weight in a healthy range can reduce your risk of at least 12 different types of cancer, including bowel cancer. And it does this by keeping inflammation and your hormones in check. We know that maintaining a healthy weight for many people is not just a case of eating less and moving more. However, eating a healthy, balanced diet, being physically active, getting enough good quality sleep, reducing stress, and minding your mental health can all play a part in weight management and therefore help you reduce your risk of bowel cancer. And there are supports available. This slide lists out some of the support options and resources that are available for healthy eating, physical activity, sleep, and mental health. I appreciate it is a very busy slide, but I think it does show the wealth of information and support that is available to you and available freely online. And you'll have access to these links after the webinar. And of course, if you do require referral to a weight management specialist or a weight management consultant, your GP should be your first port of call. alcohol can increase your risk of 7 different types of cancer, including bowel cancer. Alcohol breaks down into a chemical that can damage DNA and stops the body being able to repair itself. The Department of Health has published lower risk drinking guidelines. However, when it comes to cancer, unfortunately, there really is no safe lower limit. So for information and tips on cutting back, visit askaboutalcohol.ie or contact the HSE Drugs and Alcohol Helpline for support in changing your alcohol intake. And again, these contact details will be available after the webinar. As Dr. Una Kennedy has already discussed today, smoking can increase your risk of lung cancer as it contains approximately 70 different chemicals that cause cancer. But smoking also increases your risk of bowel cancer. So whilst the best way to reduce your risk of bowel cancer is to not smoke in the first place, for those who do smoke, the best thing you can do is to quit. And it's never too late to stop, but the sooner you quit, the better. We know that quitting smoking is hard, but the HSE Quit services are there to help you along the way. And again, the HSE Quit service contact details will be made available to you after the webinar. Finally, to reduce your risk of bowel cancer, we recommend everyone between the ages of 59 and 69 take part in the free bowel cancer screening programme that's available in Ireland. Bowel cancer screening aims to detect signs of bowel cancer at an early stage before you've even noticed any symptoms yourself. We've already heard today about how effective bowel cancer screening is at detecting bowel cancer early. And the next speaker today will go into it in a bit more detail. But make sure if you're between the ages of 59 and 69 that you are registered for bowel cancer screening. And once again, the contact details for registration will be available after the webinar. So as you've heard today, there are a lot of steps that we can all take to reduce our risk of bowel cancer. And you can start by making a few small changes today. I'd like to thank my colleagues for putting this webinar together today, and thank you all very much for your attention. And I'm happy to take any questions either in the Q&A function or during the Q&A section after these presentations. Thank you very much.
Thank you, Katrina, and we'll have you join us on the panel as well. So now I'm going to move on and introduce our last speaker for today. So our final speaker will be Professor Pádraig Mac Mathúna, who is Clinical Director of the Bowel Screen Programme and an alumnus of the Mater Hospital, having worked as a consultant gastroenterologist. And today he'll be speaking to us about the bowel screening programme and the early signs and symptoms of bowel cancer. So over to you, Pádraig.
Good afternoon, everyone, and I'm delighted to be asked to participate in this World Cancer Day webinar on lung and bowel cancer. My name is Pádraig Mac Mathúna. I'm the Clinical Director of the Bowel Screen, which is the National Colorectal Cancer Screening Programme as part of the National Screening Service. And again, it's very important that I think that this significant cancer, including as well as lung cancer, is highlighted today. And I really appreciate the Irish Cancer Prevention Network with its 5 agencies all supporting this event. My task really is to highlight the importance of recognizing early bowel symptoms and also then to give you an overview of the Irish Colorectal Cancer Screening Programme, or Bowel Screen. The National Screening Service, or what does it do? Well, currently it is a screening program for 3 cancer three cancers: bowel, breast, and cervical, as well as a screening program for individuals with diabetes, where they have their retinal screen in an attempt to prevent blindness. And screening is important to aim to find early signs of disease. It's essentially for people who do not have symptoms, and that's an important distinction between individuals who are entirely well as opposed to having symptoms. And the whole concept of screening is to find early disease before the person has symptoms, intervene, and therefore prevent the progression of disease and reduce the mortality. As regards bowel cancer, there are some very important facts to keep in mind. The bowel, or the large intestine, includes both the colon and the rectum. And almost 3,000 people a year are diagnosed in the country. It's the second most common cancer in men and third most common cancer in women, I think, which is under-recognized. And most people develop the disease after the age of 60, and about 1,000 people a year die from this disease. So it's an important public health issue. We feel that the number of cases may increase in the next 10 years as people get older, which is the same for all disease, including all cancers. So therefore, screening has a potential important role in making an impact on the potential mortality from this disease. So let's look at the early signs and symptoms that people should be aware of and bring to their attention of their general practitioner. And again, this includes both people who've had a screen test or not. And symptoms can develop between screens. And again, just to emphasize, the screening is for individuals who do not have symptoms. And I clearly mentioned already that if the screening, the emphasis on screening is finding early disease or pre-cancer disease that we can intervene on. If you have a change in bowel habits, again, over a period usually of 4 to 6 weeks, if there's a feeling that you haven't emptied your bowel properly, if you have pain, unexpected and prolonged pain, feeling very tired, which may reflect anemia, or like shortness of breath, likewise, which may reflect anemia, or if you've had unexpected rectal bleeding. All of these require attention, and they should trigger a visit to your GP, who then can make the decision whether you need to have further tests or not. And this is entirely separate from the screening program. So how does the bowel screen program work for you? Well, if you're between the ages of 59 and 69, you'll be included in the program, and the first home screening test will be sent out to you between your 59th and 61st birthday. And this is important because up until last year, the entry age was 60, and we've reduced it by 1 year now, and we'll continue to reduce it in the coming years. The test will be offered as a home test every 2 years, and you need to be on the bowel screen register to receive an invitation, and how to get on the register and how you're contacted is available again through the helpline and websites that we'll highlight at the end of this talk and throughout the afternoon. You'll receive an invitation to take the home test kit, and if you accept, the test will be posted to you to your home address. This is a simple little test that you should leave beside the toilet in your bathroom, and when you're having a bowel motion, a small sample of your stool is taken with a specific little stick. It's put into the little container that you can see on the right-hand side, into a self-addressed envelope, and then sent back to the laboratory. And this tests whether there's any invisible blood in your stool that wouldn't have been apparent to you. And in turn, if that is the case, then we can offer further screening tests. So the test comes back to the central laboratory, and that will tell us whether there's traces of blood in the stool or not. And again, we can send our results back to you at home within 4 weeks. The vast majority of people get a normal result, over 95%. In other words, no detected blood. And if you're between those ages of 59 and 69, you'll be asked to retake the test in a couple of years' time. Again, emphasizing the fact that in the meantime, if you develop any symptoms that we mentioned earlier on, it's important to go to see your doctor, regardless of the fact that you're in the screening program. This is important because the screening program is not foolproof. The abnormal test, the presence of blood may be intermittent, and therefore when the test is taken, you may or may not be having some bleeding, and therefore it's limited. It has limitations in terms of accuracy. If you get an abnormal test, we'll invite you for the test called colonoscopy. And that will be carried out in the in your local hospital, depending what part of the country you live in. So colonoscopy is an examination of the colon. And this is a photograph of a typical endoscopy unit in the country where the person is sedated, asleep on the trolley with two nurses and the endoscopist. And the thin tube is placed in through the rectum, and it navigates through the colon, and the picture is up on a video screen. And it looks for signs of precancer changes called polyps, or in fact, cancer. And just to reiterate, if 100 people have a colonoscopy, we find cancer in about 3 to 4 people, but we find up to 50 people have polyps. And the polyps are the small growths which we remove because they're the precursors, or they're the changes in the bowel that in turn may go on to cancer. So this is a valuable exercise in taking away any pre-cancer changes in the bowel. And again, in general, if 100 people have a colonoscopy following a positive FIT test, we found about 50 people, about 50% have polyps. So this is a valuable test. After the colonoscopy, we have a chat. All in the endoscopy units, the nurse and the doctor will have a chat with you about the result. The vast majority of people will have a non-worrying result, either normal, or if the polyps have been taken out, then a surveillance plan is made for you on the day. In the small number of people who have cancer or significant large polyps that require further surgery, then referral is made on through the nurse specialists for you to have further tests with a view to seeing the oncology and surgical colleagues. But again, it emphasized that the majority of individuals who have cancer found during a screening colonoscopy test have an excellent outcome. Up until this year, we included people between 60 and 69, but it's important, according to the national strategy, to gradually reduce this age slowly towards 55. Like everything in relation to screening, it's your choice, and there are some additional help in terms of websites, videos, and in multiple language, given that we're a multicultural society. And again, most of this information available online is easy to understand, and it definitely should address any concerns that people have about participating in the screening program, including what's involved in the FIT test, the potential for colonoscopy, and the fact that it's a positive step in terms of cancer prevention. So just to summarize the program, if you are 59 or older up to the age of 69, you'll receive an invitation to participate. And we've reduced the initial age from 60 to 59 last year, and we'll continue to reduce it towards mid-50s in the coming years. As I say, if you're not on the register and haven't been contacted, it's simple to get on the register by calling the free phone number here or registering through the Bowel Screen website. We'd encourage you to participate in the program, and once you get the FIT test, to put it beside the toilet at home. The sample collection from your stool at home beside the toilet is simple. Put it into the little container and send it off in the post, and we'll come back to you with the result in a few weeks. So these are the points of contact: with website, email, free phone. All the information is there. In our view, I think it provides a level of reassurance of what the program involves, the target population, the potential outcome, and the fact that this is a positive public health measure in reducing the mortality from colorectal cancer, improving the health of the population, particularly both men and women over the age of 60. So thank you very much for your attention, and we will be able to participate in a question and answer session later on.
Thank you for that, Porrick. And I'm actually going to invite all of our speakers to join us again on screen. So we have Dr. Una Kennedy, Dr. Katrina Kelly, and Professor Porrick McMahon are going to join us for questions. And just to say thank you to everyone for sharing your questions on the Q&A. There are quite a lot of questions coming through, so we're trying to get through as much of them in the background as we can, and we'll also answer a few of them here live as well. So thanks for our speakers. We might start with you, Porrick. Just a lot of people have been asking around about the age range for bowel screening, and just if there are any plans to extend the age range for bowel screening. You've mentioned the current age group.
Yeah, it started at 60 to 69. We've reduced it to 59, and the plan, according to longer term strategies, to gradually move it down in the coming years to 55. And HICWA is also examining the potential for it to go down to age 50 based on international practice. However, Trina, one of the limiting steps in expanding it has been the demands made on colonoscopy throughout the country, and all the patients that have colonoscopy as part of the screening program have it in their local hospital, which currently is dealing with the large amount of patients having colonoscopy for symptomatic care. So we occupy about 10% of the colonoscopy population, but hopefully with increased capacity and resources, we can gradually increase the years down towards 55 in the coming number of years. So we've made inroads this year.
That's great. So to 55 anyway is the plan, and then anything lower than that would be just depending on the evidence and what can be seen.
That's right.
That's really helpful. Yeah. Thanks. Just staying with bowel cancer, I might just move to Katrina in terms of the modifiable risk factors, and just question whether there's any kind of specific diet that you'd be recommending around reducing bowel cancer risk, or specific foods to avoid. I suppose a few questions along those lines.
Thanks, Trina. I suppose there's no specific diet that we would recommend when it comes to reducing your risk of bowel cancer, but there are two big kind of take-home messages from this that I think people should try to implement. The first one is that it's important to increase the amount of fiber in your diet. So that means eating plenty of vegetables, fruit, whole grains, and pulses. That would be things like lentils or chickpeas. So try and increase the amount of fiber in your diet would be the first thing. And then the second recommendation I'd make is to try and reduce your intake of red meat. That's things like lamb and pork or beef. And to try and cut out processed meats. And by processed meats, I mean things like salamis or chorizos or hot dogs. However, again, when it comes to diet, I don't think it really should be an all or nothing approach. Even try to make some small changes, like having a meat-free Monday, where you just don't eat any meat on that particular day, or have an extra portion of vegetables with your dinner every day.
Thanks, Katrina. And I'm not sure if the next question is for you or for Porrick, but because it's not really a modifiable risk factor, maybe, but there are questions about if you have a family history of bowel cancer. So if you want to comment on that first, is your risk increased if there's a history in your family?
Yeah. So no, go ahead.
No, go ahead. You want to go first, Katrina, or Porrick?
I would just say that, yeah, having a first degree relative, so that's a parent, a sibling, so a brother or sister or a child who has been diagnosed with bowel cancer, can increase your risk of bowel cancer. And that's particularly if they were diagnosed at a younger age. And then there are certain genetic conditions which run in families, which can also increase your risk of bowel cancer. But even at that point, regular bowel cancer screening and making those lifestyle choices that I would have talked about earlier can help to reduce that risk.
Thanks, Katrina. Porrick, do you want to add anything to that, or?
Yeah, I'd agree with Katrina's view. The family history is important, and it's something we're aware of in many cancers. And some high profile celebrities, for instance, the area of breast cancer, have highlighted the importance of BRCA gene. Now, as regards family history, the genetic tests Katrina mentioned are, again, very helpful in a small number of patients. They probably specific genetic syndromes probably account for about 3 to 4% of all the colon cancers. But individuals with significant family history, again, it's something we're increasingly aware of. we would advise people to discuss it with their GPs, and more hospitals, particularly in the cancer centres, are aware of the importance of family history and can give specific advice. As it stands, the Bowel Screen program is not, it doesn't incorporate those individuals, but again, there is emerging expertise within clinical genetics to help guide those people as to if they need a genetic test, or if it's not, when and where they should have a colonoscopy, regardless of age.
Thanks, Porrick. And I suppose a related question then for Una, because similar, it's been asked, is there, is a family history significant when it comes to lung cancer? Is there a genetic risk for lung cancer? Or how much of a role does that play, would you say?
Hi, Trina. Thank you. It doesn't play a very strong role for lung cancer. There is a phenomenon we all know about with cancer called familial clustering, where you may get one or two or more first-degree relatives who may have a cancer, and they would be, as Katrina said, your siblings, parents, or the children who might have a diagnosis of cancer. But of course, if there's a cancer cluster in a family, it doesn't always mean it's a genetic problem or a hereditary problem. It can also be that people are exposed to the same environment or exposed to the same agents, such as cigarette smoking. There is some evidence in the literature of familial clusters that suggest there may be a hereditary susceptibility to lung cancer, but particular gene variants haven't been found for that, and there's no genetic testing for it. So the best we can say is that if you have a first-degree relative with lung cancer, that's a sibling, a parent, or a child, that can mean that you have an increased risk of lung cancer, and simply need to take all the steps that we all should be taking anyway, which is not smoking, and keeping fit and eating healthily, and watching out for signs and symptoms and getting onto them as soon as we see them.
Thanks, Una. And with a specific question around, I suppose, within a household, it's really looking at actually fireplaces and open fireplaces, and whether coal dust, fine ash, is that something that's a risk as well that people should be concerned about?
Possibly. IARC, which is the International Association for Research on Cancer, would classify biomass that's wood burning as a probable lung carcinogen. And there, certainly we know that smoky, as opposed to the smokeless coal, can increase your risk of lung cancer. And women seem to be more susceptible to this than men. But it's difficult to quantify how much wood or coal to burn and for how long, and it's difficult to measure in terms of ventilation as well. But there does seem to be an association between wood, smoke, and lung cancer. Yeah.
Thanks, Una. And maybe just sticking with lung cancer, in terms of it, you mentioned a lot of the signs and symptoms to watch out for, and encouraging people to go to their GP. So, could you just give a brief overview of what happens if you go to your GP and you're concerned? What would be the likely path there?
Yeah, I mean, it depends on the person. I mean, the likeliest thing is if you pop in to see somebody like me, if there's a genuine concern for lung cancer, usually the first step would be a chest X-ray. And the chest X-ray may show something, it may not. It won't always pick up a lung cancer. I think that surprises people, but it's not always easy to see everything on a chest X-ray. So it won't always be clear on a chest X-ray. If it shows something, or sometimes even if it doesn't, you can be referred to the rapid access lung clinics. And as I said, there's 8 of them around the country, 4 in Dublin, 4 outside Dublin. I fill out the electronic referral form. It gets there straight away. In the rapid access lung clinic, they triage it. Depending on the urgency, they will call you. And generally speaking, if they think it's important to see you quickly, they will see you quickly, and they'll start doing the appropriate tests then. So it's a very quick system when it needs to be.
Okay, thanks, Una. If we go back to bowel cancer, actually, one question asked was just to clarify bowel cancer and colon cancer. Porrick, if I can ask you, just for people to say, is there a difference between them, or are they the same thing?
No, it's the same thing.
Yep.
Same thing, and bowel, colon, and the intestine are all the same. The only differentiation we make would be colon and rectum. Although strictly speaking, it's a continuous pipe. But there's some difference in treatment. But when we use the word colon and bowel, they're interchangeable.
Yeah, so we use them kind of interchangeably, but we're talking about the same disease. And then you said the rectum just being maybe the further down part of the bowel. With the bowel screening program, I suppose, can we say definitively at this stage that that screening has made a difference? You know, can you see the impact of the bowel screening program in Ireland? Yes, do you know?
That's an important question, because the hard endpoint of all screening programs, whether it's breast, cervix, or bowel, is, does it make a significant impact on mortality? Ideally, does it reduce the mortality on the disease by over 25%, and therefore are there 25% more people surviving? The analysis shows that it's heading that way, that the program has been up and running for over 11 years now. And the initial analysis carried out by HICWA, again, to see whether this program was going to be worthwhile, indicated that we would see the results in about 10 to 14 years from the time. And a lot of it depends on the amount of people taking up the opportunity to participate. And therefore, what we're speaking about today, in terms of the screening program, is encouraging people within the age range to participate. And obviously, if very few people are participate, it won't make much an impact on the mortality. But the more people that do, it will, because we've targeted the age at the age when people develop these pre-cancer polyps. And there, the real value of the program is to finding these changes that are pre-cancer, removing them, and therefore preventing cancer in the long run. In that way, it's analogous to the cervical smear in picking up pre-cancer changes. So we're analysing the data and looking at the survival and mortality every year. It's going in the right direction. We anticipate we will see significant impact in the coming few years. I mean, what you'd like to see is less and less people presenting to the hospitals with advanced colon cancer requiring significant surgery, chemotherapy, radiation, which are a big drain on the resources. So that's the best case scenario.
Thanks for that, Padraig. And maybe we'd be happy to take the next one as well, as in terms of, or Una as well, but I'll ask you first, Padraig, around people with irritable bowel syndrome type symptoms. And do you find that people with those symptoms that can get confused with bowel cancer symptoms? And, you know, how do people sort of differentiate what's important and what to act on and go to your GP with?
Yeah, no, I saw that question written down. It's an important one. Irritable bowel syndrome is extremely common in the community. It usually affects people much younger than in the cohort that we're looking at. So we're identifying people that develop bowel cancer over the age. Most people are over the age of 60. So we're targeting them as they get to that age. Irritable bowel affects much younger population, but the symptoms may overlap. So abdominal pain, cramping, a variable bowel habit. Rectal bleeding is not associated with the irritable bowel syndrome. And in individuals that are concerned, I think the important thing is not to worry about it too much, but to go and see their GP. And depending on their history, and depending on the symptoms that put together, they may or not require colonoscopy, which will clear the air for the majority of individuals and give them reassurance.
Okay, we just have one final question on bowel cancer, Padraig, which is just to check if aspirin is helpful in preventing the development of bowel cancer.
Yeah, very interesting question. This all stems from a study that was carried out in the States many years ago, looking at the health in a large cohort of American nurses, women. And what they did is they looked to see whether aspirin would help reduce getting the number of heart attacks. So they looked over a 10-year period to see, well, what was the outcome of this? Some nurses took aspirin, some nurses didn't. They took placebo. And they found that didn't actually make much difference in terms of preventing heart attacks. But for some reason, they found that there was people who took aspirin had less colon cancer, which was unexpected finding. This drove a lot of research, and it's now shown that aspirin, the way it works in terms of painkillers, it also works in terms of reducing the progression to cancer. Now, we're not in a position to put aspirin in our cornflakes every day to prevent. It doesn't work like that.
Not without harm.
Not without harm. And the downside of a large amount of aspirin, unfortunately, is bleeding from the stomach. It causes stomach ulcer bleeding. So theoretically, a drug that works in the same way to prevent the progression of polyps again is very attractive. But on a public health measure, the idea of giving aspirin in people who have polyps, it's a variable. The data is unclear, but there is a reasonable school of thought to say that if you have a polyp former and you have any tendency towards cardiovascular disease, being on aspirin will reduce your chances of developing further polyps. And so you may get a 2 for the price of 1 kind of benefit.
Okay, thanks for that, Morgan. Sorry, I think we lost you briefly there, but I think the sound is back now. I think we have time just for one more question, and I might bring it back to Una, because in terms of reducing risk, I suppose tobacco is always going to be our number one, I suppose. And a question around NRT, and what exactly NRT stands for and is, and how do you access it?
Yeah, it's nicotine replacement therapy, and nicotine NRT stands for nicotine replacement therapy, and it is very useful for helping people quit cigarettes. It's very difficult to quit cigarettes, and most of the time you do need help with it. The statistics are that if you try to quit on your own, you've about a 7.5% chance of quitting. With nicotine replacement, it goes up to about 15%. And if you throw in nicotine replacement and counseling, it goes even higher, up as high as possibly even 30%. So I would strongly urge anybody to avail of all the help that they can get to boost their chances of quitting cigarettes. And the really good news is that the nicotine replacement therapy is available free of charge, even if you don't have a medical card, if you go through the smoking cessation counsellors. And as you can see in the slides there, I got in straight away and got to talk to them really quickly, even though I don't smoke and don't need a smoking cessation counsellor. They were very pleasant to deal with. So there's a lot to love about it, and very few reasons not to avail of that service when it's there and it's free and it works.
Okay, that's great. Thanks for that. We might close our questions off now, and thanks to all of our panelists for joining in the discussion. And in terms of, I suppose, our closing address, I'd firstly just like to thank in particular Mary Kennedy, our patient, for sharing her story today, our 3 speakers as well for sharing their expertise, and hopefully there's been a few take-home messages. I think it's heartening that, while these 2 cancers are so common, it's good to see that there's actions that we can all take. So whether that's being alert to symptoms and acting on them, participating in the screening program, or making changes in our own lifestyles. And I think 2 themes in particular that came through a lot of the talks today were that even a small change can make a difference, or secondly that that supports are available. So I suppose reflecting what Una was just saying there, that don't go it alone. If you're trying to make a change, whether it's quitting smoking or being more active physically, that it really is to avail of the supports that are there. So thank you all for sharing that today. I'd like to thank the Irish Cancer Prevention Network members as well for their ongoing support and collaboration. So Breakthrough Cancer Research, the Marie Keating Foundation, the Irish Cancer Society, the National Screening Service, who work with us here in the National Cancer Control Programme. If anyone watching today would like to sign up